You are asking all the tough questions. So that's first of all, you can't, you can't just like question a patient, like, just off the bat, like, hey, we don't really have pain, right? Because then you don't want to put the patient on defense, right? So, you want to treat the patient. And if they have pain, you treat the pain, right? But you kind of have to look at the history too. So, are they seeing do they have a provider that they're actually seeing for this condition patient, and they're it's regular, right? So you're looking at cures. So it's always a different provider who's prescribing these opiates. Are they the same opiates, or the doses like always kind of changing, the quantity is always changing if they're actually shopping for providers to get a prescription, right? If you see something like that, that's kind of a red flag that potentially this patient is may not have a real pain issue, and it's kind of pain seeking, right? But if you're saying that this patient is getting prescribed the same opiate every time, the same provider in the same quantities, that's less likely that there's something unsavory going on, right? So that's one thing that's a very pharmacist approach to looking at pain medications. Next thing, I mean, this was getting into like the part where pharmacists aren't supposed to diagnose, right? But you have to know what's going on. So we kind of look at, well, what does this patient have pain for, right? So this patient's like, well, we have cancer and we have end-stage cancer. That's obviously the reason why they have pain. There's a real reason for it, right? Versus like non-specific chronic back pain with no specific history of the injury or something. Then you kind of like start wondering what's going on with this, right? Versus like, so you have to look at why they need the pain. And, to treat pain, you want to be able to treat it, give the lowest amount of opiates to treat the pain effectively, right? So that's one thing you want to do. So usually if we don't have any history about these patients and we'll give, short acting medication to kind of gauge what their pain requirements are, right? So short acting opiates. Once we have an idea of what is necessary to keep your pain controlled, then we would switch you to a long-acting opiate, right? So long-acting opiates have a less risk for abuse because they are sustained release versus when giving a short-acting opiates, you get that rush, and that's when you directly get that high, right? When you give just enough pain medication opiates to treat the pain, you're less risk for the secondary gain. It's when you take more than you really need, so higher doses than you need. So for example, if you only needed 5 milligrams of oxycodone to get adequate pain relief, but you're actually still taking more than that, like I'm taking 10 milligrams or 20 milligrams or asking for it more frequently, that's when you run the risk of getting high, right? So when you're prescribing, you want to make sure you're giving basal pain relief and you're giving PRN that's spaced out appropriately and not at excessive doses, right? So that you don't start a new patient who has a real risk for pain and potentially get them addicted to it.